guys, I'm Mahima Soni, a final year student from GMS Sola, and I am going to be talking about neonatology in this video. So, what is a neonate? A child or a baby who is from 0 to 28 days old is called as a neonate. So, this neonatal period can be classified into two types. Two parts. One is the early neonatal period, and the second is the late neonatal period. Early neonatal period is from 0 to 7 days, and the late neonatal period is from 7 to 28 days. So now what happens is the importance is that out of all the neonatal deaths which are going to occur, 3/4 of them occur in the early neonatal period, that is within the first week of life. So now let's look at some specifications of a newborn. This is something that has to be remembered. There's no way around it. So first is the length. Length is 50 centimeters. Head circumference should be around 35 centimeters. Heart rate should be about 110 to 160 per minute. Respiratory rate is 40 to 60 per minute. Normal temperature is 36.5 to 37.5 degrees Celsius. The first urine has to be passed within 48 hours, and the first meconium, or the meconium, which is the first stool which is passed by the baby, has to be passed within 24 hours, but sometimes it may take up to 48 hours also. So now we are going to classify the baby according to the gestational age. According to the gestational age, we have three kind of babies. One is the small for gestational age babies, then we have the appropriate for gestational age babies, and the last is the large for gestational age babies. The small for gestational age babies are when the weight of the baby is less than the 10th percentile. It is known as a small for gestational age babies. Another name for these kind of babies is also IUGR, which is the intrauterine growth retardation. Now second is the age appropriate for gestational age babies. So in this, what happens is the birth weight will be between 10th to the 90th percentile, and the large for gestational age babies, they are large for the gestational age, so the birth weight has to be more than the 90th percentile. So now we have IUGR. So IUGR can further be classified into symmetrical IUGR and asymmetrical IUGR. So in symmetrical IUGR, what happens is that the length, weight, and the head circumference, all three specifications of the baby are small. So there is the baby will be proportionately small, we can say, and the main cause is intrauterine infections in the early part of pregnancy, and the Pondler's index will be more than 2. We'll talk in the next slide about what is Pondler's index. Now, asymmetrical IUGR babies, in them what happens is length and the weight are less, but the head circumference remains normal. So due to this, what is going to happen is that the head will appear large because the rest of the body is smaller. So here we can call here we are going to say that they are asymmetrical IUGR babies. So over here there occur complications from the middle to the late pregnancy. For example, like preeclampsia may occur, and their Pondler's index is going to be less than 2. So Pondler's index. What is Pondler's index? It's also known as a corpulence index. It is a ratio of a person's height to their weight. It can apply to any age group, but typically we are going to use it in pediatrics to assess the ratio of height to weight of a person. The formula is height, which is in meters, upon the cube root of weight, which is going to be in kg. So a weight of the baby. As we saw earlier, the weight has to be about 2.5 kg. So now when the weight of the baby is going to be less than 2.5 kg, we are going to call them low birth weight babies. And when it is less than 1.5 kg, they are known as very low birth weight babies. And when it is less than 1 kg, it is known as extremely low birth weight babies. So low birth weight babies, that is less than 2.5 kg weight. So those kind of babies can either be preterm or premature, or they can be IUGR babies. So IUGR babies are the most common cause of low birth weight babies in the developing countries, and preterm or premature babies are the most common cause of low birth weight babies in the developed countries. So now let us see further. So as we saw before, preterm babies and IUGR babies both can have low body weight, but the difference remains that preterm babies are going to be born before 37 weeks of gestation, and the IUGR babies, they can either be preterm or they can be term babies also. But the specific thing over here is they should be less than the 10th percentile of their weight. So now let's talk some things about the umbilical cord. So first let's look at the anatomy of the umbilical cord. So in anatomy, when we are going to look at the cross section of the umbilical cord, we are going to see two arteries and a vein. So over here we can I have highlighted the umbilical arteries, as you can see, and there is the umbilical vein over here. Over here you can see that the umbilical vein is seen. Now usually there are two umbilical arteries, but sometimes there may be a single umbilical artery also. So if there is a single umbilical artery, then that child is going to have, or we can say that they'll be predisposed to having congenital kidney disorders, congenital gonadal abnormalities, congenital GIT disorders, for example esophageal atresia, or the congenital heart deformities. Now clamping of the umbilical cord. So in clamping, delayed cord clamping is practiced, that is about 60 seconds after birth, and you're going to clamp 2 to 3 centimeters away from the umbilical stump. In cord clamping, as we said, we talked about delayed cord clamping. So the benefit of delayed cord clamping is that when we are going to delay the cord clamping by 30 to 60 seconds, we are going to allow additional transfer of blood from the placenta to the newborn infant, and doing so is going to improve the hematological status, the iron status, and clinical anemia also. It is practiced both in term as well as preterm babies. However, if the baby is asphyxiated, then you do not have to do delayed cord clamping. You have to immediately clamp the cord and start resuscitation. So the umbilical cord is going to fall by itself from the 7th to the 10th day. So how do we have to take care of the umbilical stump? Normally what we have to do is we just have to keep the area dry. However, in India, in community settings where the cases of septicemia are higher, you are going to clean the area with 4% chlorhexidine to prevent infections. Now in umbilical cord, we have some umbilical cord remnants. So we have two remnants basically over here, the Whittling duct and the allantoic duct. So Whittling duct, it connects the umbilicus to the GIT, and the allantoic duct is going to connect umbilicus to the allantois, which is further going to form the urinary bladder. So what happens is both of them are going to involute by themselves at birth, but sometimes they do not involute and they remain patent. So if they remain patent, what is going to happen is in Whittling duct, it is going to connect the umbilicus to the GIT. So all the fecal matter or the GIT matter will come out from the umbilicus. And similarly, in allantoic duct, what will happen is it remains patent, then the urine or watery discharge will come out of the umbilicus. Then we have umbilical abnormalities. There are many abnormalities, but over here basically we are going to talk about two abnormalities: umbilical hernia and the umbilical granuloma. So umbilical hernia, in most cases of umbilical hernia, no treatment is required, and it is going to resolve on its own when the child reaches about 6 years. But we have to send them for surgical reference if the umbilical ring size is more than 1.5 centimeter. And then we have the umbilical granuloma. So in umbilical granuloma, we have a red granulation tissue. We can see bleeding or mucus discharge from the umbilicus. And over here, the treatment, if it's a small granuloma, we are going to cauterize it with silver nitrate. Here there are two pictures. This show on the one on the left shows the umbilical hernia, and the one on the right shows the umbilical granuloma. In umbilical granuloma, we can see some reddish discharge coming out. So now let's talk about the body temperature. Babies are very sensitive, and their body temperatures have to be maintained at a very specific level, very specific range to prevent hypothermia. So in body temperature, we can classify it into normal temperature, hypothermia, or hypothermia. So normal temperature, as we talked earlier, is 36.5 to 37.5 degrees Celsius, and if the temperature goes above 37.5 degrees Celsius, we are going to term it as hypothermia. If it goes below 36.5 degrees Celsius, we are going to call it hypothermia. Now, hypothermia can further be classified into three types. One is the cold stress, which is mild hypothermia. Then we have moderate hypothermia, and then we have severe hypothermia. So cold stress or mild hypothermia is 36 to 36.4 degrees Celsius. Moderate hypothermia is going to be 32 to 35.9 degrees Celsius, and if the temperature goes below 32 degrees, it is going to be called as severe hypothermia. So we have something called as a thermoneutral environment. Now, thermoneutral environment is a narrow range of environmental temperature in which the baby is going to have the lowest BMR and oxygen utilization, but still the body temperature is going to be normal. Now, a thermoneutral zone is different for babies of different gestational ages and postnatal ages. It is higher for low gestational age babies, and it is lower for clothed babies, naked babies, and during initial few days of life. Normal temperature of a nursery or a NICU has to remain between 25 to 28 degrees Celsius. This is very crucial. Now, how are we going to measure the temperature of the baby? So we need a low reading thermometer, about 30 degrees Celsius. Now we can do it by thermometer, or we can do it by palpatory method, which is by touching the body, especially the hands, feet, and the abdomen of the baby with the back of the examiner's hand over here, from here. So if we are going to find hands, foot, as well as abdomen, everything is warm, then we are going to call it normal temperature. However, if the abdomen is warm but the feet are cold, then it is mild to moderate hypothermia. And if we have cold feet, hands, and abdomen, everything is cold, it is severe hypothermia. So, how frequently are we supposed to examine the temperature of the baby? If it is a healthy baby, we are going to measure it once daily. If it is a healthy but small baby, that is 2 to 2.5 kg weight baby, so we are going to measure it 2 to 3 times a day. And if it is a very small baby, it is less than 2 kgs in weight, then we have to measure it 4 times per day. However, if the baby is sick, then we have to measure it every 2 hours. So, heat loss. Heat loss in newborns. Newborns are prone to heat loss There are many reasons due to which newborns are prone to heat loss. One is that they have poor heat regulation mechanism. They have a larger surface area to body weight ratio. Their body weight compared to the surface area of the skin is very less. So they have larger surface area from which heat loss can take place. Their skin is thinner and more permeable. They have less subcutaneous fat, and after birth, they're exposed to the external environment, which generally has a lower temperature. So, there are four sources of heat loss. Heat loss, usually it can occur by conduction, convection, evaporation, or radiation also. So, when we see at birth, the most common method is going to be evaporation, that is loss through the skin. It is inevitable, but we can decrease it by drying the baby. That is why we see that after the baby is born, it is vigorously rubbed and it is thoroughly cleaned and dried. After that, we have radiation. After birth, the most common method for heat loss is radiation. In that, heat loss will occur from the surrounding environment, which is colder than the body temperature of the baby. However, the surrounding environment is not in contact with the baby. Then we have convection, which is a source of cold air in the room. For example, it can be a AC. And then we have conduction, that is when the baby is in direct contact to a cold surface. For example, a cold surface like the tray in which the newborn is kept after birth. So therefore we see that whenever the newborn is kept in a tray, the newborn is not directly in touch with the tray. So over here we can see those mechanisms in pictures: radiation, heat loss via the electromagnetic waves from skin to the surface, then convection through the currents of air, evaporation when water is going to evaporate from the skin of the baby, and conduction, direct heat loss to solid surfaces which are in contact with the baby. Now we have signs of hypothermia. We come to signs of hypothermia. So in hypothermia, what happens is there will be peripheral vasoconstriction. So we can see acrocyanosis, the cool extremities, delayed peripheral capillary refill time, that is delayed CRT. There is less restlessness, and then the baby will become lethargic. There is poor weight gain. If there are repeated attacks of hypothermia, or recurrent hypothermia is going to occur. In cardiovascular system, we can see bradycardia, hypertension, raised pulmonary artery pressure with resultant hypoxemia, tachypnea, and distress. Neurological depression is seen, and we are going to call it neurological depression if we can see lethargy, poor reflexes, decreased oral acceptance of food and water, and apnea. There is difficulty in the enteral intake due to abdominal distension, vomiting, and feeding difficulties, which is going to lead to poor weight gain, as we saw. And then if we have severe cases of hypothermia, then acidosis, hypoglycemia, oliguria, azotemia, and generalized bleeding can also be seen. And as I said previously, babies with chronic cold stress are not going to gain weight properly. So now there is a mechanism which is known as brown fat lipolysis. It is also known as a non-shivering thermogenesis. So it is a mechanism of heat generation in newborns. So location of brown fat. Brown fat is located in very specific regions. One is the nape of the neck, one other is the axillary areas. Then we have perirenal areas, that is around the kidneys, and the interscapular areas, that is between the scapulas. So when norepinephrine or adrenaline is released, brown fat lipolysis starts. So due to that, heat generation is going to occur. Now in this, what happens is that the heat generation is going to occur at these specific places, and then the blood is going to pass through these areas which are going to have brown fat and heat generation has occurred. So what happens is the blood is going to become warm and the warm blood will start circulating. Other than that, we have some methods of keeping a newborn warm. One is the radiant warmers, then we have incubators, then we have polyethylene racks, then we have skin to skin contact, as we can see in the kangaroo mother care. Then we have thermal mattresses and a warm room. So in this picture we can see a radiant warmer. Then over here, this is a picture of an incubator. This is a picture of an incubator. The incubator is a closed cabin or a closed box which is going to keep on circulating the warm air around the baby to keep the baby warm. So now there is something which is called as the servo control. Now in servo control, what happens is there is an inbuilt feedback system which is going to control the ambient temperature of the incubator. So what happens is that this indicator is going to measure the temperature. Indicator or sensor is going to measure the temperature of the baby, and according to that, it is going to adjust or alter the heater output to maintain the optimum temperature. And then in a radiant warmer, we have a similar system, but in the radiant warmer, as we saw earlier, a radiant warmer, this is the open system as compared to the incubator, which is the closed system, and both of them have the servo control mechanism for maintaining the temperature. Now we come to neonatal reflexes. So neonatal reflexes, there are many reflexes which occur. We have adult reflex. We have reflexes which are seen in adults also. But how can we say that this is a neonatal reflex and this is a normal reflex? So there are certain criteria which have to be fulfilled. So first criteria is that the neonatal reflex has to appear in the intrauterine life. It has to be present at birth. It should disappear after birth. And if it is going to persist, it is going to indicate that there has been some brain damage. And the other thing is, this is an involuntary reflex. So, primitive neonatal reflexes. So, in primitive neonatal reflexes, we have 4 neonatal reflexes. The first is the grasp reflex, second is the rooting reflex, third is the Moros reflex, and fourth is the asymmetric tonic neck reflex. So the grasp reflex, it is going to appear at 28 weeks and disappear at 4 months. Rooting reflex appears at 32 weeks, disappears within 1 month. And the Moros reflex, it appears between 28 to 32 weeks, it disappears between 3 to 6 months. And the asymmetric tonic neck reflex appears at 35 weeks and disappears at 4 months. So let's see what a grasp reflex is. So as we see in this video, let's see, when a pen or finger is put in the palm of the baby is going to grasp it. So this is known as a palmar grasp reflex. And now let us see the rooting reflex. See. So as we see in the rooting reflex, what happens is when the side of the cheek of the baby is touched, the baby starts sucking. This helps the baby in suckling breast milk. Then we have the Moros reflex. Now in this reflex we have 3 phases. First is the fingers will open, then the arms will open, and the third phase is that they are going to embrace it. Yeah.
Okay. So now we're going to check the Moro reflex. This is a startle reflex, so you might want to do this one near the end of your testing in case the kiddo becomes upset. The onset of this one is 28 weeks and the integration is 5 to 6 months. The procedure has you have the kid in midline and drop their head back. Oh, we should see his arms extend out. Know though that he doesn't always do that, so I'll try that one first, and then if not, then I'll show you where it looks like you're almost gonna sort of drop him, and we want to see those arms splay out. Okay, so there you see the arms go back, and I can try it again, see if we can get a little more drastic one. There we are, and the arms went out and came back in, and that's what we're looking for.
Now we have the asymmetric tonic neck reflex. This is also known as a fencing reflex. So what happens over here is that when the baby's neck is going to be turned towards one side, for example, let's turn it towards the left side, then what is going to happen is that extension of the arm and the leg will occur on the side on which neck has been turned. For example, if we are going to turn it towards the left side like this, then the hand will be the hand and the leg of left side will be extended, and the right side is going to be in flexion like this. So over here, as we see in this picture, and then the importance is that it is going to promote the hand-eye coordination in the baby. There are some reflexes which are going to appear after birth also. They are the parachute reflex and the symmetric tonic neck reflex. These, however, cannot be called as neonatal reflexes because they do not appear in the intrauterine life. The parachute reflex, it appears after 6 to 9 months, and it's going to persist throughout life. It is a protective reflex. So when we are going to stimulate the baby to fall, then what happens is like he's going to extend both of his arms in front of him and try to protect his own face like this. So this is also known as a paratrooper reflex. Now even we show this reflex like when we are going to fall down or something. The first instinct that goes is we are going to throw out the hands to catch ourselves. So that is the parachute reflex. Then we have the symmetric tonic neck reflex. So this appears after 5 to 6 months, and it disappears at 10 to 12 months. It helps in crawling. So when the neck of the baby is going to be extended, the legs and hips will be in flexion, and both of the arms will extend themselves. So as we see in the picture, it is going to help in crawling. Like this is the stage after which the baby will start crawling. And now we come to something known as the Apgar score. Now Apgar score is used as a criteria for evaluating a newborn after birth. So there are 2 times when Apgar score is put into use for evaluation. That is 1 minute after birth, and the second is 5 minutes after birth. So however, this Apgar score is not going to help us in guiding the steps of neonatal resuscitation for a very simple fact that neonatal resuscitation has to start immediately after birth, while the Apgar score is not calculated until after 1 minute of birth. So we cannot use it for guiding the steps. However, when we have calculated the 2 Apgar scores, we can see the changes in the 2 Apgar score, which will reflect that if the baby is responding well to resuscitation attempts or not. If the Apgar score at 5 minutes is less than 7, then we are going to extend the score at every 5 minutes till 20 minutes are done. Like we are going to find the score. This is known as an extended Apgar score. So in Apgar score, basically we have 5 criteria, and each criteria is going to have 2 points. So the maximum number of points that the baby can have is 10 over here. And according to the Apgar score, we can classify the baby in 3 things. First is the normal baby. The second is moderately depressed baby, and the third is the severely depressed baby. If the score is more than 7, it's a normal baby. If it is 4 to 7, then it is a moderately depressed baby, and if it is less than 3, then the baby is severely depressed. So what are the 5 features or the 5 criteria of Apgar score. First is the appearance, second is pulse, third is grimace, fourth is activity, and fifth is respiration. So we have 0, 1 and 2 score which can be given. So in appearance, if the baby is pink, then we give a score of 2. If the extremities are blue but rest of the baby is pink, that is peripheral cyanosis will be seen, then we are going to give it a score of 1. However, if the entire baby is pale or blue, then we give a score of 0. Then pulse, if the pulse is more than 100 per minute, then it's score of 2. If it is less than 100, score of 1. And if there is no pulse at all, we give score 0. Grimace, like when the baby is going to cry, it has like a strong cry and it's going to pull away, then it's given a score of 2. If it grimaces or has a weak cry, then a score of 1. And if there is no response to the stimulation that we are going to give, then it's a score of 0. In activity, if the baby is actively moving, then score 2. If the arms and legs are flexed, that is score 1. And if there is no movement at all of the baby, then it is score 0. And in respiration, if there is a strong cry, then score 2. If there is slow and irregular cry, then score 1. And if there is no breathing at all, then score 0. So basically what happens is we have to add up all the scores which are there, and then we have to find out the total, and according to that we can find out if the baby is normal, moderately depressed or severely depressed. Thank you.